I'd like to call Dr. Furquan Ulhaque. Dr. Furquan, is he here? Ulhaque. Okay. So the next person, Dr. Stavan Chirag Amin.
Good afternoon, I'm Dr. Stavan from JJ Hospital. I'm presenting a talk on lateral condyle fracture of the humerus with posteromedial elbow dislocation in children, a case series and review of literature. So, as you all know, lateral condyle fractures of the humerus are very common injuries in the pediatric age group. They are, however, rarely associated with dislocation, and literature is sparse. So, we report a case series of Mills type 2 fractures with posteromedial dislocation of the elbow. So, as we all know, the Mills classification of the lateral condyle humerus fractures, the type 1, where the fracture line traverses lateral to the capitalotrochlear groove, and the type 2, where it traverses through it. So, when it traverses through the groove, the elbow is unstable. And numerous management modalities have been described, like closed reduction and K-wiring, open reduction and K-wiring, open reduction and K-wiring with a tension band wire, as well as open reduction and screw fixation. In our experience, open anatomical reduction is the crucial part, and fixation using a combination of screw and wire in our series is found to be the best method. So these are the aims and the objectives of our study. And we also performed a review of literature on the subject, the functional outcomes using different management modalities for this type of injury. So our case series was a case series of 9 patients, 7 male and 2 are female, all within 6 to 13 years of age. And they were initially given a splintage and taken to surgery. So this was the inclusion and exclusion criteria of our study, which was obviously it was a pediatric age group study. We only included Mills type 2 fractures in our study and closed trauma. Patients with distal neurovascular deficit, non-unions, malunions were excluded from our study. So this was the approach we did. This is the operative pattern. We took the standard lateral approach. We opened all cases. The soft tissue that was interposed within the fracture fragments was removed, and the fracture fragments were anatomically reduced and fixed using 1 K-wire and 1 screw. And closure was done if possible, because in some cases the swelling was very severe and we could not achieve closure. It was left open. Post-operatively, the arm was given a long arm back slab and suture removal was done on the 12th day. The K-wire was removed at around 15 days post-op, and range of motion exercise was started after confirmation of bony union, which was usually around 3 weeks to 1 month. So here are the functional outcome scoring systems. The two that we used in our study was the Flynn criteria and the Mayo elbow performance score. Here is the Flynn criteria, which takes into account the cosmetic and the functional factors. The Mayo elbow performance score is a more comprehensive scoring system, which takes into account pain, motion, stability, and function, and a total of 100 points. So this is a case from our study. A 6-year-old male presented to us with the Mills type 2 lateral condyle fracture with severe swelling, so severe that we initially suspected it might have been a compartment type injury. So we operated it open with with open reduction first. The fracture fragment was flipped on its head, so the articular surface was into the fracture line. We flipped it around and then we fixed it with a K-wire and a screw. The wire was passed parallel to the joint line and the screw perpendicular to the fracture line so as to achieve compression. Primary closure was not, we were not able to achieve primary closure, but we took tack sutures, and when the wound went on to heal secondarily. At around post-op day 12, we removed the sutures that we had taken, and the K-wire was removed at 2 weeks post-op, and mobilization was started after 3 weeks. So here the follow-up. This is the 6-month follow-up X-rays of this patient. As you can see, the The wound has healed with a hypertrophic scar. The range of motion, the flexion achieved is almost full, extension is full. And as you can see, there is no varus valgus deformity at the elbow. Here is a short video. So in such injuries, there are a few treatment alternatives that have been described in literature. The most commonly done is open reduction with 2K wire fixation, and it has satisfactory outcomes. A tension banding procedure has also been described in literature. So these are our results, the results of our study. The mean time to surgery was 2 days. And primary wound closure was not possible in 3 out of 9 cases. All went on to show bony union at a maximum of 6 weeks, all mostly around 3 to 4 weeks. And mean MEPS was 91.88, which is an excellent score. Here are the results of similar studies that are done in literature. So Cheng et al., who did ORIF with 2 K-wires, Tomori, who did K-wire and TBW combination, and Rasool et al., who did again with K-wires, and Sharma also with 2 K-wires. So all of them have achieved a good to excellent scores. Here's a review of literature. In multiple systematic reviews, they have found that complication rate is significantly higher in the presence of elbow dislocation, which is a main determinant of outcomes. So there are poorer outcomes in the dislocation group, obviously. And another systematic review revealed that open anatomical reduction is critical to avoid cosmetic and functional problems in these injuries. So our study underlines the importance of open anatomical reduction of LCH fracture. No significant difference in functional outcomes in a 2-wire versus a wire plus screw combination was found. And multiple case series that were performed in the past, in the 1980s, 1960s, they showed that they were attempted with closed reduction, which showed very poor outcomes over the long term, which again underlines the importance of anatomical reduction. Prior planning by experienced individuals and not missing this injury is a critical step in management of these injuries. And due to the rarity of these injuries, studies are sparse, but still we need more comprehensive studies and long-term follow-up.
Okay.
Thank you.
Any questions from the audience?
Yes, sir.
Just come and collect your certificate.
Oh.
I'd like to call Dr. Kiran B.
Hello, good afternoon everyone. Today I am going to present you the topic related to the comparative treatment for the traumatic shoulder instability in young male patients between the arthroscopic Bankarts and Open Latarjet Procedure. As you know, anterior dislocation is a frequent sport-related trauma. It is accompanied by labrum, ligament, even bony lesions of the glenohumeral joint. In up to 67% of the cases, the initial conservative treatment fails. Despite the operative treatment, instability still recurs in young male patients. In a history way back in 1923, Bankart repair was described, and in 1954, Latarjet procedure was described. In the Bankart procedure is the most commonly used surgical intervention to treat the shoulder instability. Here, the torn labrum and the inferior part of the anterior half of the inferior glenohumeral ligament is anatomically attached to the glenoid rim. Coming to the Bankart's procedure, in the first image it's showing the lesion over the anterior inferior part of the labrum. Later the lesion is curated and debrided and the edges are freshened, and the 3 holes are made in the anterior part of the glenoid, and the suture anchors were passed inside it. Later the knots were taken out to the labrum and it's tightened. So the anatomy of the glenoid has been maintained. In spite of the Bankart's repair, the dislocation rate may recur in up to 54% of the cases in 10-year follow-up. So in the recent years, Latarjet procedure, there's a bony block procedure is gaining popularity. It involves the non-umbilical transfer of the coracoid process along with the conjoint tendon to the glenoid neck. For these reasons, the Latarjet procedure has been favored as a primary treatment modality for the traumatic anterior shoulder instability. For the briefing regarding the Latarjet procedure, the osteotomy team is made at the base of the coracoid process, and the anterior inferior part is approximated towards the defect along the glenoid wall, and it's been fixed with screws. The aim and objective of this study is to compare the success rate between the arthroscopic Bankart's procedure with the open Latarjet procedure. The hypothesis is that the open Latarjet procedure resulted in the fewer complications compared with the arthroscopic Bankart's repair in the treatment of traumatic shoulder instability in young male patients. Material methods, we conducted a prospective study with a study population of 12 cases. Inclusion criteria include young adult patients between the 16 to 25 years of age and the clinically documented instability using a positive apprehension test with a jobs relocation test. And for the cases involving the involuntary dislocation, subluxation, or the fear of shoulder dislocation of the primarily conservatively treated traumatic shoulder dislocation. We did the preoperative plain film CT MRI was carried out, and the CT is mainly used for the assessment of the bony deficiency in the glenoid. The enrolled patients were randomized into the group B, that is arthroscopic Bankart's operated, and the group L, that which is open Latarjet procedure operated. After the operation, all the patients were received physiotherapy after 3 weeks, and the active exercises were started after 6 weeks, and the force restricting activities were restricted up to the 3 months. The patients was clinically followed up at regular interval of 3 months, 6 months, 1 year, and 2 years post-operatively. Intention to treat analysis were used to analyze for the primary and secondary outcomes. As you see the CT scan, in the first image, it's showing an end-face view of the glenoid, where you draw a circle along the board of the glenoid surface with the maximum diameter, and between the edges of the defect, glenoid defect, you draw the tangential line. If the tangential line is more than the 50% of the maximum diameter of the circle of the glenoid surface, then it's a significant bone defect. Like in a similar way, you take an axial cut of the glenohumeral joint, make a circle along the proximal humerus, and draw a tangential line between the two ends of the Hill-Sachs lesion. If the tangential line is more than the 40% of the diameter of the humeral head, then it's a significant Hill-Sachs defect. Coming to the results of the study, among the 12 patients, 6 were operated with the arthroscopic Bankart's repair, that is group B, and another 6 patients were operated with the open Latarjet procedure, that is group L. The mean age of the patients were 21.4 years, weight is 68 kgs, right-sided 2 among 6 patients in group B and 3 among 6 patients in group L. The 1 cases in each the group has having hyperlaxity, and the 2 cases in each the group is having the significant Hill-Sachs lesion and the bony Bankart's lesion. The competitive sports-related activity was having in 3 cases in group B and 2 cases in group B. 1 patient had a redislocation in a group B, and no dislocation happened in the group L. This case was subsequently reoperated with the open Latarjet method. There are no treatment-related complication in either group or no progression of glenohumeral arthritis. Coming to the conclusion, the arthroscopic Bankart's repair carries the significant risk of short-term post-operative dislocation rate and the need of additional surgery. The Latarjet procedure was associated with a higher rate of return to the previous level of competitive sports. Additional remplacement was reserved in the 40% and in the group B and the 10% in the group L. The Bankart's operation was associated with the lower complication rate compared to since it's a minimally invasive procedure. Despite the redislocation rate, the short-term patient-related reported outcome was similar in both the Bankart's and Latarjet procedure. Limitations include the short-term follow-up, and you can't predict when the instability occur. A young male patient and a female and older than is not included. Coming to the few.
Thank you. Before I give you your certificate, I think this is a flawed study because you're comparing apples with cabbages. Primary Bankart for a primary dislocation is different, and things where you have a big Hill-Sachs and glenoid loss, that is multiple dislocations. You cannot compare these two.
Yes, sir. If, the main
Come and collect your certificate. Come. Thank you.
So, Vinay Shyam Samant.
Good afternoon, everyone. Mechanical alignment has always been the dictum followed by knee surgeons. Having a joint line which is parallel to the ground and a neutral limb alignment is always what one desires desired out of a total knee replacement. Yet 20% of 20% is the dissatisfaction reported in TKR patients. A part of which can be attributed to the concept of constitutional varus, which represents a significant proportion of knees in the population, fitting the concept of perfect total knee replacement to knees that are not so perfect can be a reason for the dissatisfaction. That is when the concept of kinematic alignment was brought in, where we tried to mimic the native knee alignment during total knee replacement. It is associated with better intercompartmental pressure differences and lesser soft tissue release or bony recuts are needed to achieve the same. But while doing kinematic alignment, there are certain questions that come into your mind, like how can one predict the native knee alignment when arthritis has already set in change in the alignment? Second, what should be the target for kinematic alignment? That is when the concept of C.P.A.K classification was brought in. It uses a novel concept of arithmetic HKA, which is the hip knee ankle angle, and joint line obliquity. Arithmetic HKA is novel because it is a reliable marker of the constitutional knee alignment, irrespective of setting in of the arthritic knee changes. Joint line obliquity used terms like apex proximal, apex distal, and neutral, which cleared the ambiguity which was present in previous classifications. The previous study was done in Caucasian population, and hence for application of Ka in Indian population we needed an Indian study. The aim of our study was to find the distribution of these C.P.A.K knee types in Indian scenario and to compare that between a healthy and a osteoarthritic population. We also aim to find out the constitutional varus in Indian population. We studied 450 knees, 250 of which were osteoarthritic, while 200 were of healthy type. They were divided into two groups, and each knee was classified using the procedure laid down by C.P.A.K classification. This is a short inclusion criteria and the exclusion criteria. We calculated, we used scanograms for this study, standing scanogram, and there were certain measurements that were made, which is, we briefly calculated the LDFA and MPTA, which is the lateral distal femoral angle and medial proximal tibial angle. Using these two angles, we calculated AHKA, which is the arithmetic HKA, not the mechanical HKA. Arithmetic HKA is the difference between these two values. Now, if the arithmetic HKA falls between -2 to +2, it becomes a neutral alignment type. If it is less than -2, it becomes a varus type, and if it is more than +2, it becomes a valgus type. So AHK is a measurement of the limb alignment. Similarly, joint line obliquity, if the values fall between 177 to 183, it forms the neutral type. Similarly, less becomes apex distal and more becomes apex proximal. Now, using these two variables, put it against each other, we find a 9 C.P.A.K types matrix, including which use these two concepts that were introduced in the C.P.A.K classification. Similarly, we classified our knees into this classification. It's a beautiful matrix in which the knees that are depicted in each quadrant are the actual knees that we found out during our study. If we compare the demographic comparison between the two groups, the osteoarthritic group was older with a mean age of 59. The female proportion was more in the osteoarthritic group. If we compare the alignment types in both the population, the varus alignment was the predominant type in the osteoarthritic group, while the neutral alignment was commoner in the healthy group. Comparing the joint line obliquity, the apex distal type was the commonest found in both the groups, and a similar distribution was seen in with respect to joint line obliquity. If we compare if we compare the distribution of all these 9 types into these two populations, we find that the varus types, which are 1 and 4, are commonest in the osteoarthritic cohort, while the neutral types 2 and 5 are commoner in the healthy cohort. The four types 1, 2, 4 and 5 are commonest in both the study groups, while the remaining have a similar distribution in both the study groups. This is just a brief representation. So the four commonest types seen in Indian population are virus types 1 and 4, while the healthy types 2 and 5. If we compare the level of virus types 1 and 4, it is more in comparison with the healthy group. So virus with apex distal, that is type 1 and type 4, have an odd ratio of 2.8 in the arthritic group, and type 4 has a odds ratio of 2 in the arthritic group. Whether having a native knee anatomy similar to that of C.P.A.K types 1 and 4, which is varus with apex distal or neutral, predisposed to knee osteoarthritis, needs to be further researched, and a deeper insight of knee dynamics in these high groups need to be studied to improve kinematic techniques. Important confounding factor here could be the older age group that we had in the arthritic population, as arthritis and old age both have more common incidence of virus types. But as we said that we use the concept of AHK, which is a predictor of pre-arthritic alignment and not the alignment which comes with arthritis. Second, one important finding that we found out that Bellman in his original study, the virus population was about 32%, but in our study we found out that 48% of the Indian population had virus dynamics. So very high percentage of Indian knees are found to have constitutional varus. The high prevalence of constitutional varus in Indian knees may account for high prevalence of knee osteoarthritis, and it being more common for Indians as compared to Caucasians. Also the aim for...
You can shift to the conclusion.
So types 1, 2, 4 and 5 are the commonest C.P.A.K types found in Indian population. The virus types 1 and 4 occur more commonly in the arthritic group. And as constitutional virus is commoner in Indian knees, hence a kinematic approach caters to majority of the population. And further research is needed to understand which Indian knee types benefit the most from kinematic alignment.
Thank you. It's an interesting study, but there's one basic fact, that there are two main cuts, the distal femoral cut and the proximal tibia cut. If you don't get those right, your knee is going to fail. Please collect your certificate. Well done.
So, the next candidate, Dr. Dilipin Chakravarti. Hello.
Hello, thank you. I would like to acknowledge my authors. We have no financial disclosures to make. Pedicle screw fixation in osteoporotic pain is challenging. Acute catastrophic implant failure can occur with screw pull-out due to weak bone screw interface. Augmenting pedicle screw with cement or sublaminar wires is one of the way of increasing pull-out strength. But there are some complications associated with these techniques. Cement augmented screws can have cement leakage and embolism, and revisions are difficult with screw extraction. With sublaminar wires, there is a potential for neural injury with repeated passage of stainless steel wires. Wires can cut out through the soft bone, and postoperative MRI are difficult to interpret due to artifacts. Sublaminar bands of polyester material are an alternate method for augmentation which does not have these complications. But the cost of these bands is prohibitive. We try to find a cost alternative and thought of using Merslin tapes. The first mention of use of Merslin tapes is from 1986 by Robert Gaines, who used in pediatric patients. The aim of our study is to assess the safety and efficacy of sublaminar Merslin tape augmented pedicle screw fixation as a low-cost modality for spinal instrumentation in osteoporotic vertebral compression fractures. This was a retrospective study of consecutively operated patients for osteoporotic fracture at 2 centers with a minimum follow-up of 12 months. Only single vertebral osteoporotic fractures in thoracolumbar spine who were not operated previously were included in the study. Indications for the surgery were either neurological deficit or dynamic instability or both. All the patients were operated with the posterior approach with pedicle screw fixation, 2 levels on either side. All cases we did a transpedicular reconstruction of anterior column and the screws were augmented with sublaminar Mercelin tapes. Technique of Mercelin tape augmentation we used this as follows. After exposing the interlaminar space, a double loop of 20 gauge horseshoe sublaminar wire with one vicryl suture crimped at the tip of the is inserted in the usual fashion. Then just the vicryl is pulled out using a skin hook and sublaminar wire is removed. After that, 2 wet Mercelin tapes are simultaneously pulled back under the lamina with the help of vicryl as shown. Each Mercelin tapes were passed over the rod around the screw tulip and both the ends were manually knotted with maximum tension. We noted these primary and secondary measures. Outcome of 40 patients were analyzed. The average age of the patients was 72 and the average follow-up time was 18 months with a minimum of 12 months. And almost 80% of the fractures were T12 and L1. There are no radiographic screw loosening and pull out and no revision surgeries for construct failures. Our functional outcomes were satisfactory. We calculated the ODI, VAS score and neurological status. Out of 30 patients with neurological deficit, all except 2 recovered completely. We found an average 5-degree loss of correction at the final follow-up. This cadaveric biomechanical study found that osteoporotic spine screw augmented with tapes provided a better fixation than those without augmentation. Another cadaveric study showed that cutout force through the tapes was significantly higher than the stainless wire in osteoporotic bone. This is due to the fact that force over the tape is distributed over a wider area than compared with a thin SS wire. We found one clinical study from Japan which has used sublaminar tapes for augmenting pedicle screw for osteoporotic fractures. In Japan, they use 90 centimeter long wires. Instead of Mercelin, they use polyester material similar to Mercelin, but used a sliding knot technique and they used a tensioner to tighten the tapes. The limitation of our study is that we don't have a comparative group. We have relatively short follow-up with a limited number of patients. We don't have a follow-up CT and hence we cannot comment on the decision of screw loosening and fusion status. And importantly, our technique has a potential flaw that we are not using a tensioner, but judging the tension in the tapes by manually knotting them. Mercelin tape augmented construct relies on the lamina for its hold, which is the strongest spot in osteoporotic vertebra. And it avoids a long implant construct and also avoids a cement-related complication. And Mercelin tape is a radiolucent material and does not affect the postoperative MRI. Thank you, sir.
Well done.
So have you compared the complications or the failures you've had with your procedure to the Z score of the patient? I mean, in that case, what I want to ask is, have you done the DEXA scans to declare that they're osteoporotic, or to what extent?
Yes, sir, but the osteoporotic fracture is itself, by definition, is a fracture. So we are using DEXA scan as a follow-up, sir.
No, what about knowing what is the Z score in all these patients before the operation? To see how osteoporotic they already are.
Okay.
Okay?
Okay, sir.
That's, I think, something important.
Okay, sir.
But this is a good idea. You never mentioned about what is the actual strength of the Mercelin tape.
Yes, sir. The actual strength of the Mercelin tape is around 1,500 Newton torque, sir.
And what about the Dacron tape?
So Dacron tape is 1,800, but the cost is very high.
The cost is about 25,000.
Yes, sir, 25,000 per Dacron.
And Mercelin tape?
2,300, sir.
So it's 1/10.
It's a 1/10 cost effective.
Okay. But it depends on your strength that day. If you've had breakfast, it will be a tighter
Yes,
knot.
sir. Yes, sir.
All
Actually,
right.
we don't have a tightener to tighten.
Well done.
Next speaker, Rushan Azaz Khan.
Good afternoon, everyone. My topic for today is an assessment of functional outcome of surgically treated acetabular fractures. This study was conducted in Sion Hospital. So, as everybody knows, acetabular fractures have an indirect mechanism, and they are usually high energy trauma. With the indirect mechanism, it is usually a blow to the greater trochanter, a blow to the knee, a flexed knee and hip, and a blow to the foot when the knee and hip are extended. If left untreated, displaced acetabular fractures can lead to development of premature arthritis of the hip and cause havoc in a patient's life. So the aims and objectives of our study was first to assess the functional outcome of patients that were treated with open reduction and internal fixation, and also as a byproduct to study the rate of conversion to total hip arthroplasty for patients treated for the same fracture within 18 months. So our methodology was quite simple: single center study, a combined retrospective and prospective study. When the patient was admitted, while prepping the patient for surgery, we give them a questionnaire and get the pre-injury Harris hip score of the patient. Then the patient is taken up for surgery, open reduction internal fixation, and then the post-surgery Harris hip score is taken at 6 weeks, 12 weeks, 6 months, 1 year, and 18 months. So this was our inclusion and exclusion criteria. Basically, the inclusion criteria included the acetabular fractures resulting in an unstable hip joint and excluded all the fractures which resulted in a stable hip joint, like stable non-displaced fractures, low anterior column fractures, low transverse fractures. Even both column fractures with a secondary congruence were excluded. So I'll explain the methodology with a simple case. This was a 52-year-old male with a history of road traffic accident, and as you can see from the X-ray and CT scan images, he suffered a posterior wall of acetabulum fracture with a hip subluxation posteriorly. All of our patients, 29 out of the 30 patients, were operated using a lateral or a floppy lateral position with the Cocker-Langenbeck approach. And our implants used were a simple recon plate and screws. This is a post-operative X-ray showing good article reduction. These are the Jude views. So with the results, what happened with the results? So as we saw in our study that most of the fractures, majority of the fractures were posterior wall fractures. Then it happened mainly 86.7% in males due to predisposition for road traffic accidents in males. And then the Harris hip score. The baseline we took as 100, and as you can see, over a period of 6 weeks, 3 months, up to 18 months, there was an increase with a mean of 88.57 at the end of the study. So there was a maximum increase in the Harris hip score from 6 weeks to 3 months, indicating that at 3 months we have started the patient with the weight bearing. So how do you interpret this Harris hip score? Between 90 to 100, it is considered as excellent. 80 to 90 is considered good, and 70 to 80 is considered fair. So for a satisfactory outcome, we choose excellent and good. So the second part of our study was to determine the rate of conversion to total hip arthroplasty because of the premature arthritis of the hip after a seemingly well reduction of the fracture. This patient, at the end of 18 months, developed significant arthritic changes, as you can see, which required a total hip arthroplasty in the end. So at the end of 18 months, we had a 3.33% rate of conversion to total hip arthroplasty. So this interpretation we have seen. How does it compare with the other studies? From 1986, starting from Mata's landmark study on functional outcome of acetabular surgeries, our study was also at par with all the other studies similarly done. So at the conclusion, we know that the fractures of acetabulum involve weight-bearing joints of the lower limb. Hence, they must be restored as much as possible. Despite these best attempts, malreduction and inadequate fixation of acetabular fractures may occur. In those cases, Total hip arthroplasty may be needed in fracture when the primary fixation fails. Thank you.
Thank you. Any questions from the audience? Sir, would you like to ask any question?
Well done.
Thank you so much.
So I'd like to call Dr. Furquan if he's available. Dr. Furquan. So you can conclude the session. Thank you.
We finished early because there was one speaker less. So whoever's on for the next session can please start if they'd like to.